I'm Suvinay, and let me take you again to some of the common shoulder pathologies that we can see on an MRI. So again, my goal today will not be to teach you a lot of theory. It is going to be a little bit of theory and more about practical aspects that you should know when you're reporting an MRI shoulder, about the common pathologies and what actually the orthopedic surgeon needs from the reports, right? So I'll just switch off my video and let me start. You can keep asking me queries in between, right? I just keep looking at the chat box as and when needed. And at the end of the session, we can have a discussion then, right? So first, I'm going to talk about rotator cuff pathologies. So rotator cuff pathologies, they can be either due to direct trauma or it can be chronic repetitive trauma, which is happening due to repetitive overhead abductions, right? So either it is a normal tendon which has undergone direct trauma, or it is a normal tendon with repetitive chronic. I think someone wants me to start the video, so I'll start. Right. So either it is a repetitive chronic trauma over a normal tendon due to overhead repetitive abduction activities. Secondarily, it can happen due to a abnormal tendon. So abnormal tendon or a degenerative tendon. That can be due to some sort of subacromial impingement, right? Or it can be due to hypovascularity in the distal parts of the tendon. So whenever we report rotator cuff pathologies, either we are seeing some sort of degenerative pattern in the tears, or we are seeing rotator cuff pathologies in settings of trauma. So the three important zones that you should be aware are the foot plate or the anthesis of the tendon. Then we have the critical zone of the tendon, and then we have the myotendinous junction here, right? So why it is important to identify all the three features? So foot plate or anthesis is the attachment site where the tendon is blending inside the bone. Now there was a concept of critical zone in which this is the zone which is approximately 1.5 to 2 centimeters proximal to the attachment site along the bone, and it is said to be critical because there was some hypovascularity documented in the literature along this tissue. However, recent literature is refuting these features, but for theoretical perspective, let us know, all of us should know that this is the critical zone. Thirdly, this is the myotendinous junction. So what is happening here is the tendon is blending into the muscle. So I hope you guys are well versed with the anatomy after seeing the previous lectures. So this tendon, if you are able to appreciate, this is the spinoscapula. Above that we have the supraspinatus. Below that we have the infraspinatus. So this is actually the supraspinatus tendon, which is attaching on the mid superior facet of the greater tuberosity. And these are the three critical parts that we should understand and know whenever we are describing any pathology, right? So then we have rotator cuff tendons. There are two common pathologies. Either if there is tendinosis or tear. Now, tear can be either partial thickness or a complete thickness. Now, if it is complete thickness, it is pretty much clear. But when we have partial thickness tears, they are divided into three types. So one is articular sided. So this side is called as the articular side, which is near the glenohumeral joint. Then second is the bursal tear, which is near the bursa, that is the subacromial subdeltoid bursa. And third one is the interstitial tear. So we are going to discuss about each type of tear in the subsequent slides. So this slide I've borrowed from my friend Dr. Chetali. So this is an excellent slide depicting the pathology. So what happens normally a tendon that whenever you see it on a T2 weighted image or a proton density image, it should appear as black and hypointense, right? That is because the water molecules, these white dots that we are seeing are the water molecules, which are which are tightly interlocked and present within the tendon. So when there is tendinosis, what happens? There is loosening of the collagen fibers. So what we are seeing here is the loosening of the collagen fibers, and the water molecules are slightly able to move freely. So whenever they're moving slightly freely, we are getting an hyperintense signal, that is tendinosis, right? And what happens in a tear? There is disruption of the fibers. So whenever there is disruption of the fibers, then what we see is complete absence of the tendon, and the water molecules can again move quite freely. So this is a normal progression, normally normal tendon. Water molecules tightly packed. Then we have tendinosis, and then we have tear in a degenerative pattern type of tear. Okay, I hope you understood. Let me show you images. Now, tendinosis has been divided into three types, that is mild, moderate, severe, depending upon the degree of the softening that we are seeing and the bulkiness of the tendon. So, what happens in tendinosis? So, there is inherent uh, softening of the collagen fibers. There is inherent edema within the fibers, and then there is loosening of the collagen fibers. So, how it reciprocates on an MRI? Your normal hypointense tendon that we are seeing here. Sorry, just give me a moment. So, what we are seeing here are a normal tendon here. So, this is how hypointense the normal tendon is. Then we have some tendinosis here, and then we have a diffusely bulky tendon, and there is inherent there is the tendon is furthermore bulky and hyper intense. So these are types of tendinosis. So it can be mild when there is only subtle hyperintensity without increase in the size. Just give me a moment. I'm sorry. Then we have a diffusely bulky tendon and there is inherent hyperintensity. The third type is furthermore that the tendon is not following its normal collagen path and it is further swelling outside of its path. So these are subtle grades which you can assess. With time, you will be able to identify how types of tendinosis are there. Ideally, what we are seeing is severe tendinosis or moderate tendinosis or mild tendinosis. Sometimes it might be tough to differentiate between moderate and severe. This is just a classification that has been put forward for your academic purposes. Next, now what we are seeing here is normally and most commonly reported as tendinosis is this thing. So what we are seeing is there is certain hyperintensity within the tendon. So this is a proton density sequence, right? So what we are seeing is a proton density sequence. And in this proton density sequence, we can see certain hyperintensity. But the corresponding T2 coronal section of this does not show hyperintensity. So can anyone tell me what this is called? On a proton density images, we are seeing certain hyperintensity. On the T2 weighted images, it is not seen. So what is it called? Yes, so this is a magic angle artifact and most commonly seen in the supraspinatus tendon in the shoulder and most often it is reported as partial tendinosis in many of the reports that I see day in and day out. Why there is this magic angle artifact? Because the tightly bound collagen fibers are approximately at an angle of 54.74 degree from the main magnetic axis and they appear hyperintense. This primarily happens in sequences which are low TE values, right? So why we should substantiate our MRI with a high TE value or a T2 plane in a coronal is to alleviate or obviate the magic angle artifact. And so what we are, this hyperintensity is basically artifactual and the tendon is normal. So please don't label supraspinatus tendinosis in all the patients that you see. Be wary of the magic angle artifact. Try to see that pathology in all the three planes and always, whenever possible, take a high TE sequence. That is a T2 weighted image in at least coronal or sagittal plane to avoid magic angle artifact. Right? Now, apart from that tendinosis, what we can see is sometimes intratendinous cystic changes because of the mucoid material expansion. That the mucoid material may go inside the tendon. It can reach up to the myotendinous junction. For example, this is a supraspinatus tendon, and we can see mucoid material entering the myotendinous junction. Similarly, the mucoid material or ganglion cyst can extend into the myotendinous junction in either of the tendons. So there is accumulation of intrasubstance mucoid whenever there is tendinosis, and this mucoid material can sometimes track along the path of least resistance. So that is along the myotendinous junction. So these are parts of least resistance, and you can get intratendinous cystic changes. Another example, for example, this is a subscapularis tendon that you're seeing, and there is some mucoid material surrounding the myotendinous junction here. And this is basically, again, intrasubstance ganglion system. It is important to report this because whenever the surgeons are reporting identifying tears or tendinosis, they should be made wary of the intratendinous mucoid material which is accumulated inside the myotendinous junction. Now coming to partial thickness tears. So what they can be either articular sided, they can be interstitial, or they can be bursal surface tears, right? So articular sided tears are basically the tears which are near the humeral head. Interstitial tears, these are normally, whenever you see the tendon, the articular fibers here and the bursal fibers are normal, and the tendon exists in the mid substance. So, why it is important to identify interstitial tears? Because when an arthroscopist goes inside and tries to probe at the tendon, he'll see the normal bursal fibers and he'll see the normal articular surface fibers. But what won't be visible is the interstitial tear which is present on an MR. Bursal surface tears are along the non-articular part, along the superior part. So this is how we classify all partial thickness tears. There are furthermore classifications on the degree of tear, whether the thickness of tear is less than 30% or more than 30%. If it is less than 30%, the treatment basically goes towards conservative side. If it is more than 30%, if it is involving rotator cable, then the treatment may go up to surgical parts.